How's it going, class? Just want to say welcome to our presentation. My name is Cody. I have my friends Ben and Blake over here as well. We'll be presenting on Tourette's today. So, Blake, can you go ahead and hit that first slide? So, first of all, we're going to talk about the symptomatology of Tourette's. Now, the trademark of Tourette's, as you may know, maybe from pop culture, from movies you've seen, from just the kind of general idea of it, is this idea of tics. Um, in order for you to be diagnosed with Tourette's, you have to have multiple tics per day, and that must take place multiple times throughout a calendar year, or even more than a calendar year. And also, you must have both a phonic tic and also a motor tic, and they must be maladaptive in nature, which would mean that it has to negatively impact your life, as well as it also has to lead to a decrease in the general quality of your life. Now, the symptomology of Tourette's can be a little complicated due to the various presences of other mental illnesses. Typically, we find in Tourette's, in one study, it was actually, I believe, 50 to 70% correlation between Tourette's and ADHD. So, in this particular study, they found that 50 to 70% of people that they tested had both ADHD and Tourette's. So that can kind of complicate the symptomology at times, as there are various things that you must take into consideration. And also, along with Tourette's and the tics, there are general behaviors that are followed, and that would be things like anxiety disorders, learning disabilities, and just typically poor social skills in general. So next slide, please. Now, just kind of going along with the symptomatology, there's also the cognitive side of things. And once again, this is something that can remain similar across various different mental illnesses. So this is a direct quote from one of the articles I was reading, and in it it's talking about kind of like the mental side of Tourette's, and it's caused by a decreased intracortical inhibition and lower resting active motor threshold on the left hemisphere of the brain. And this is something that can also be found in ADHD as well. That's kind of lending to the idea of there being a lot of similarities between the two different disorders. And once again, there's also different kinds of tics. I spoke about that earlier, but an interesting thing is how these tics are affected by the environment. In a lot of studies I have looked into, typically we find that genetics and heredity are the main causes of Tourette's in general, but it's interesting to see how the environment affects these things. So, for example, the two main things that I noticed in the article I read in particular were anxiety and stress. So, in an environment that creates anxiety, an environment that creates stress, the amount of tics that someone would suffer or that what they would experience was significantly higher and statistically relevant in that particular study. So, next slide, please. And then just, I guess, some more detail on tics. This is also a study I looked into. And in it, also Brooks and Pauls, they kind of categorize the different types of tics that are general and are usually found in people with Tourette's, and kind of group them in different ways just to make things simpler. And it was interesting to see how the variances worked out. So, for example, in group one, which was the most relevant and the most common group, this group was characterized by aggressive behaviors, and these kind of vary. It's interesting almost how they vary on a range of self-harm behavior, from things to even just like cursing out loud. So it's a very large threshold, but also that was kind of the characterization of group one. In group two, it was characterized by simple tics. This occurred in 17% of cases that were studied in this particular study, and simple tics just being things like grunting, things like just very simple twitches, and not anything as major as the group one had, for example. In group three, this was characterized by compulsive tasks, and this occurred in 14% of cases. And once again, these are very small things. For example, the compulsive need to touch an object repeatedly is something that was found in this particular group. And then finally, group four, which was the smallest major group that was found, this occurred in 10% of cases. And this was characterized, interestingly enough, by the absence of grunting, but the presence of tapping. And by tapping, this is understood to be different than the tapping found in group 3 or the more aggressive behaviors found in group 1. So now I'm going to pass it off to Blake, who's going to talk about the physiology.
All right, so the physiology of Tourette's syndrome has to do with a lot of tics, as Cody said. When you think of somebody that's going through Tourette's syndrome, it kind of has this feeling of it kind of like bubbles up. They feel like there's something they have to do, like an itch they have to scratch, or it's just something they have to do until they finally do it, and then they kind of like relieves them of this pain. So how exactly this happens, they're not so sure. What they have found is that in people with Tourette's, there's either different physiological things going on in their brain, in their body, whether it's signaling receptors or different parts of the brain. So we're just going to kind of jump into that. So what they found is that there's a lot of things involved with the basal ganglia, and what this does is it controls emotion, cognition, and some facial features, which include like blinking in the eyes, grinding of the teeth, which are common symptoms of Tourette's. Three main parts of the basal ganglia are the striatum, which is involved with downstream signaling into the pallidum, which is involved with inhibitory signals for motor movements, and the substantia nigra, which is involved with receiving signals from dopamine receptors, which is extremely important in the physiology of Tourette's. Also, what they found is overactivity in the basal ganglia is super correlated with Tourette's syndrome. And by overactivity, what I mean is that there's two different pathways that can go down with in the basal ganglia. And what they're finding is that the pallidum is just super over activated, and it's causing more muscle movements, motor movements in the head, the shoulders, that are causing these tics in people with Tourette's syndrome. So the cycle of this overactivity starts in the putamen, which is then signaled down into the globus pallidus internus, which then releases the inhibition on the thalamus, which normally stops the frontal cortex from being stimulated, which causes, so this lack of inhibition causes the frontal cortex to be more stimulated, which causes more muscle movement. So dopamine, what they found is that it plays a huge part in Tourette's syndrome and how it affects the physiology and the pathophysiology of it. So there's there's a direct pathway and the indirect pathway, like I said before. There's an increase in the direct pathway, which causes more muscle movement, and then there's a blockage of the indirect pathway, which usually stops the movement of muscles. The way this is regulated is through two different receptors, the D1 receptor and the D2 receptor. The D1 receptor is related to the direct pathway, while the D2 receptor is related to the indirect pathway. So dopamine, when it's in the body, goes and binds to the D1 receptor and causes more activity going on and overactivity in the basal ganglia, and it's also bonding to the D2 receptor and blocking that pathway completely. So there's no like feedback inhibition or anything like that going on. What happens once it activates the direct pathway, this glutamatergic cortical excitation occurs, which causes a lot of glutamate to enter into the brain, into the body, which causes more muscle movement, causes these tics to kind of just like bubble up, as to say. So this direct pathway is overstimulated, overactivated, which is causing these tics to occur. Some research done on this that has kind of shown that this is the pathophysiological way that this occurs is through research done with the caudate and putamen. As stated in the last slide, that's part of the downstream activity that's going along with this overstimulation. And what they found is that these transporter receptors are able to bind to dopamine, which is saying that dopamine is directly involved in the overstimulation of the basal ganglia. It even comes down to the genetic level. This gene here, the DR-D2 gene, is involved with making and developing, through transcription and translation, making the protein which becomes the D2 receptor, which causes the inhibition of the indirect pathway. So what happens in people with Tourette's syndrome is that this gene is highly methylated. When it's highly methylated, it's becoming inactive, and this gene is no longer making this receptor. So dopamine only has one option, which is to bind to the D1 receptor and overstimulate this direct pathway. Another thing they found, which was pretty cool, is that the more methylated the gene was, the more inactive it was, which led to more severity of the tics, whether it was more often or they were just more major tics instead of minor tics. So another big thing is in saccadic eye movement. So usually, as we learned, it's like moving from one direction to another, looking like really quickly across a room. And what normally happens here is the frontal lobe and the basal ganglia are involved here. And as we have found, people with Tourette syndrome usually have problems with this frontal cortex and the basal ganglia. So what's happening is they're having this abnormal control of the saccadic eye movement. They're not able to, do it correctly the way that people without this. So ultimately, they can't do this planned motor activity. They can't control it like people without Tourette syndrome, which is causing all these tics to occur. Lastly, they haven't found this to be completely correlated with Tourette syndrome, but they don't know why it's correlated with Tourette syndrome, but they found this in people with Tourette's. An increased low frequency brain waves, which is the theta and delta waves, and also a decrease in the high frequency waves, which is the gamma and beta brain waves. And like I said, they don't know exactly why this occurs, but they have seen this correlation in people with Tourette's versus people that don't have Tourette's with these brain waves. And then in deep tissue studies, they haven't correlated this with people in Tourette's, but what they do know is that when you have increased neuron firing patterns, when you have wave propagations, and when you have certain oscillations in the brain, this can affect both motor functioning, motor movement, behavioral movement, which is characteristic in people with Tourette's, but they do not know exactly why this difference in the brain is causing the physiological reactions that are happening in the tics and in Tourette's to ultimately cause these symptoms. So for our last section, I'm going to pass it off to Mr. Ben Smith.
Hello everyone, I'm going to talk a little bit about treatment for Tourette syndrome. We've been getting to know the symptomology and the physiology of the syndrome. Now we're going to get into how we can treat it. So there's 3 subcategories of treatment that are pretty main in this case. There's behavioral therapy, medications, and other options or further studies that are hopefully going to be conducted in the future or ones that have already been showing some improvement. So the first section is behavioral therapy. This has to do with 2 main categories. There's habit reversal. Basically what happens here is there's 4 sections of habit reversal. It's kind of a process that the person has to walk through. There's awareness, corrective training, relaxation, and contingency management. So the first one is awareness. So sometimes there's an environmental stress, or there might be some kind of movement that a person makes that causes them to have a tic or a jerk in movement, or some kind of saccadic movement in the eyes. So basically the person is told to try to identify that with a therapist, and once that's identified, they try to have a corrective training where they try to have a different movement instead of that movement that triggers the tic. So once the person has the urge to have that movement that they've identified that causes the tic, they are trying to train themselves to do a different movement to keep themselves from doing that. And then at that point, they're told to relax. So they're trying to get to a point where they can resist their urge and relax and relieve themselves of any kind of stress. As Cody mentioned earlier, there's stress and anxiety can activate tics. So there's also a component of that of trying to get the person to relax. And then ultimately, contingency management involves managing the tics and however the person might be able to resist them in any way. So the next one, comprehensive behavioral intervention for tics, or a CBIT. This is just a subcategory of habit reversal. It has components of habit reversal as well as education and more relaxation techniques and parent training, as well as different studies that are involving CBIT. So what they basically do is they use habit reversal and they try to add on education. So for an example, there might be a kid who's in a classroom and there might be a math class, and the certain section of math class that they sit in might cause them to have certain tics because of the environment or some kind of spatial awareness. It's kind of an interesting thing, but they can educate the child and the teacher, and the teacher can possibly move them to a different area of the classroom so that they will not be activated in these tics, so that they can combat the likelihood of them suffering from more tics during class. And then parent training can also help for when the child is at home and they are having a lot of problems that the parent might be able to identify, and by educating the parent, they can help reduce the tic amount at home and reduce the stress environment or whatever may be triggering it. A study that was conducted definitely supported all of what CBIT did and everything that they studied for CBIT. Second category for treatment is medications. The main medications for this is for treating the amount of dopamine. As Blake was talking about, the dopamine levels definitely influence how many tics occur. And so the main medication approaches attempt to somehow stop the production of dopamine or inhibit the receptors of some kind or block the receptors. So some of the more common drugs are guanfacine and clonidine. These are the same drugs that are used for ADHD and OCD. So these are basically because a lot of people have ADHD and OCD, also have Tourette's. As Cody was saying, 50 to 70% of people have ADHD, also have Tourette's. These drugs are commonly used in conjunction with those. Haloperidol is one of the most popular drugs. It's been used for a long time. However, it does cause a lot of bad side effects, sometimes in certain patients. So it's kind of starting to get weaned away, but it's still the most effective drug out there. Its main attempt is to block the D1 and D2 receptors, which Blake was talking about how the indirect and the direct pathways involve that. So if it can block both of the receptors for the dopamine, then it'll lead to less jerky movements and less tics. Then there's also risperidone, which is just a serotonin and dopamine antagonist, so just stopping their activity. And this one actually has a lot fewer side effects, so it's starting to become more popular. Another study was done for sodium valproate, but they deemed it as not good for children because not enough studies have been done on it and not enough information is conducted on it, and it doesn't show any better effectiveness than haloperidol, which is what they compared it to in the experiment. And so some further treatment options that are being evaluated are some music, traditional Chinese medicine, and gastroenterology. These are just 3 articles that I managed to find that are recent studies that involve treating Tourette's. So music, they actually found that it's a short-term treatment, can't be long-term, but whenever people listen to music, they experience like practically no tics or very, very few. And this was the same case for all the people who were involved in the study. Everyone who was involved with playing music or listening to music, they did not have any tics. Why this is, they weren't sure, but it had a correlation. Traditional Chinese medicine, I found a single case study of one guy who was treated for 35 weeks with acupuncture, herbs, gua sha, and lifestyle changes, and he found a 70% decrease in his tic occurrence, which is a huge change after 35 weeks. And then he actually also rated it as a 5 out of 5 and to a 2 out of 5 in the severity of the tics. The gastrodin study had to do with rats, and they were using gastrodin to decrease the amount of tics, or not really tics, but related levels of dopamine in the rats, and it definitely showed leveling effects of dopamine, and it was effective with haloperidol. So in summary, tics are the trademark of the symptomology of Tourette syndrome, and they are also phonic or motor in nature. Must be consistently present for a majority of the days for more than 1 year in order to qualify for someone to be diagnosed. The pathophysiology stems from dopamine imbalance, genetically related DR2 gene, and there are also no current cures for Tourette's syndrome, but there are behavioral therapies, medications, music, and acupuncture can be used to reduce tic incident. That is all we have for today. Thank you so much for listening to our Tourette's presentation. You guys are the best. I love Tourette.